Welcome everyone to the Silver Hill Grand Rounds program. Thank you for joining us, and we'll get started in just a moment as people settle in. All right. Hello, everybody. Welcome. I'm Jeff Katzman. I'm a psychiatrist, director of education here at Silver Hill Hospital, and we are all absolutely delighted to have you join us today, and really are privileged to welcome our very own Dr. William Pruitt, who will be presenting on the topic of ketamine treatment in mental health. And I'll have the honor and pleasure of introducing him in just a moment, but let's start with a little bit of housekeeping. Believe it or not, today's lecture concludes our 2024 Grand Rounds program, and time has really just flown by. After Dr. Pruitt's presentation today, we will have held a total of 17 Grand Rounds this year, and we're glad to say that many of you are regular participants and are very grateful for your attendance and any feedback that you provide for us. We've been busy constructing the 2025 series based on our hospital needs and gaps and all of your input. It will remain virtual with lectures on the second and fourth Wednesdays of each month. We will begin with our first Grand Rounds of 2025 on January 8th with Dr. Manesh Sharma, who will talk to us on the topic of an overview of AI, chatbots, and language of psychosis. And invitation flyers have just been sent out with reminder invitations for this program in early January. You can also, of course, always check our hospital website calendar to see the pipeline of who's coming to speak in 2025. So back to our program today. As many of you are aware, your questions really remain an important part of our Grand Rounds, and I'll moderate a Q&A discussion with Dr. Pruitt at the end of his lecture. It's really a great opportunity to put forward any questions or comments that you have for Dr. Pruitt, and please submit those anytime with the Q&A link at the bottom of the screen. If you'd like CME or CEU credits today, please complete the evaluation survey that will automatically show in your browser when we end the webinar. We will also email a copy of the survey to today's participants. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest. It is now really a great pleasure and an honor to introduce our guest speaker today, Dr. William Pruitt, who I have known now for some time. Briefly, Dr. Pruitt is an attending psychiatrist here and director of the ketamine treatment program at Silver Hill Hospital. He completed his undergraduate studies at the University of Oklahoma, where he graduated summa cum laude, and medical school at the University of Texas Southwestern, where he was elected to the Alpha Omega Alpha Honor Society. He then completed residency training in psychiatry at Yale University, and he spent a year here at Silver Hill which is one of the leaders in the field of ketamine treatment in mental health. During this time, he focused primarily on providing ketamine and esketamine for patients with treatment-resistant depression. From that experience, he developed a strong interest in helping these patients and continues that work today at Silver Hill, where he founded and leads the hospital's ketamine treatment program. And so, William, it is great to welcome you here. Thank you for the friendship and being a colleague, and I'm so glad that you are here following the year that you spent with us as a fourth-year resident, and I'm going to turn the baton to you now.
Thanks so much, Dr. Katzman, for the very kind introduction. And we'll get started. So we'll start off with some disclosures. No disclosures to make today prior to this presentation. Educational objectives. So three main ones. We're going to look at ketamine's historical background and neurobiology. discuss when to consider ketamine and which patients might benefit from this treatment, and then explore more of the details of the administration of ketamine, the subjective effects, pairing with psychotherapy, and other details of the treatment. So, some background. I think an important place to start is here with what have you heard about ketamine? This is a medication, a drug that many people have heard lots of things about. Some people don't know much about, but it tends to spend a lot of time in the news media. And so I think it's sort of important to start here with what's popularly known. So this is back in 2017. Ketamine made the cover of Time magazine as the antidepressant, and this sort of promise that maybe this is the treatment that's going to help the third of patients with treatment-resistant depression that don't respond to other treatments. Even before that, back in 2012, there are these headlines in the Atlantic: the biggest breakthrough in depression research in 50 years is ketamine. And there's this question mark, like, ketamine is such a surprising thing to be that substance, and why is it so surprising? Partially because many people might know ketamine as a recreational drug, a substance of abuse, a club drug, things like that. Also, many people have heard of ketamine as a horse tranquilizer, which it is, but it's also much, much more than that. And we'll go into that history here in a second of how it got that label. And many more recently might have heard the very tragic story of Matthew Perry, who was using ketamine at home and ended up taking a large dose and drowning in his hot tub. Also, many of these headlines seem to make the news very frequently, sort of bringing all these different things together. So a couple using a horse tranquilizer turned psychedelic superdrug, they turned to this to strengthen their relationship. And sort of finally, headlines like this: so ketamine is going mainstream. Are we ready for this? And I think this is really the question. Like, what do we make of all these different stories, these different aspects of ketamine, and where is its place in society and in mental health treatment? So first, we'll start kind of at the beginning. I think historically, there are two main stories for ketamine. First, ketamine's first life was as an anesthetic agent. Very interestingly, so actually the story of ketamine begins with phenylcyclidine, or PCP, also known as angel dust. So this drug was first synthesized in the mid-1950s with the goal of being an anesthetic agent. It was used as an anesthetic, tested in humans, and proved to have some promising useful qualities, but also the agitation that would arise in some patients when it was used as anesthesia made it really sort of unusable in a clinical setting. But researchers went about looking for alternatives that were similar, but might not have so many of these properties that made it difficult to use clinically. So it was from this research that ketamine actually was developed. In 1962, it was first synthesized. 1964, the first human trials began. In 1970, it was actually first FDA approved as an anesthetic agent. So we've had this medication with us in the health system for a very long time. In the 1970s, it was actually used very widely in the Vietnam War as a battlefield anesthetic, mainly due to its very favorable safety profile. It could be administered in the field without really any medical supervision, and it was safe for soldiers to use. It didn't drop people's blood pressure, didn't decrease respiration in dangerous ways, so it could be used when there wasn't really other medical support. And for these same reasons, it started being adopted into veterinary medicine as well, because it was good anesthesia and could be safe with less medical oversight and support. 1985, it was placed on the World Health Organization list of essential medicines. And today, it's still used very widely, across the US, especially in ERs, for things like cardioversion, minor surgical procedures. Used very often in pediatric ERs, actually. Some of you might have children who've been to the ER and needed ketamine for pain control for a minor procedure there. Also used all across the world, especially in developing countries, as an anesthetic where medical support, medical resources aren't as prevalent. And so its second history, and more importantly for what we're speaking about today, is its history as an antidepressant. So really this story begins in 2000 with a paper that was published out of Yale University. Before that, there were some case reports, some clinicians had been using it as an antidepressant, but really nothing of note until this year 2000. John Crystal, who's currently the department chair at Yale, and his group published the first paper, first clinical study showing that ketamine had very robust antidepressant effects. They're very excited about this finding, presented it widely, but really there wasn't a lot of excitement elsewhere. I think they were met with a lot of skepticism from what I can gather. And part of this was sort of the way of thinking about depression at that time. It was still very much the monoamine hypothesis of what causes depression, deficiencies in serotonin, norepinephrine, dopamine. Were what was causing depression, and ketamine works mainly through different systems in the brain, and so it's met with a lot of skepticism that this wouldn't really be a treatment that would help. But actually, that was the reason that Dr. Crystal and his group looked at this treatment, because they're just thinking there was more to the story of depression than deficiencies in serotonin signaling, and these monoamines are doing important signaling in the brain, but really very small, in the order of a few percentage of the neural signaling is happening through these molecules, and really the majority is happening through other molecules. And so glutamate is the main excitatory neurotransmitter in the cortex and the higher centers, and doing about 90% or so of the excitatory transmission in those areas. And ketamine is working through this glutamate system. And so that was part of the reason for looking at ketamine as an antidepressant, is really to probe this alternative system of depression treatment. So really it wasn't until the year 2006, a study at the NIMH that replicated the findings of that initial Yale study. And then at this point, they started getting a little more momentum, a little more excitement about the treatment. And then more and more groups began replicating these findings, that it was a pretty useful antidepressant. And this led to interest in the pharmaceutical industry. Janssen Pharmaceuticals developed a proprietary version of ketamine called S-ketamine. Brand name is Spravato, and we'll go into some of the differences between ketamine and S-ketamine a little later in the presentation. But they began FDA approval trials in 2015 and ultimately gained FDA approval for Spravato for treatment-resistant depression in 2019. And so this brings us to today, where it's sort of a very interesting and diverse environment of ketamine treatment centers. Many large academic centers like Yale, Columbia, and Mass General have ketamine treatment programs. We have one here at Silver Hill. There are many independent clinics of varying sorts all over the country. And then WonderMed is here as sort of as a representation of another sort of field in ketamine treatment, which is at-home ketamine treatment. And we'll talk about this some more later in the presentation as well. So a little bit to start us out, and we'll go too deeply into this, but touching on some of the neuroscience of ketamine. So I mentioned earlier that it's functioning mainly through the glutamate system. So ketamine is, among other things, an NMDA receptor antagonist. So it inhibits that receptor, and then that leads to AMPA receptor activation. Basically what it's doing is blocking these NMDA receptors on inhibitory interneurons. It's basically putting a brake on the brakes here in the glutamate system. And this leads to a sort of burst of glutamatergic transmission through these AMPA receptors. So a little bit about what we know about it, receptor profile on these NMDA receptors. So we'll go through this slide sort of piece by piece. So first you can see in yellow the NMDA receptor in the phospholipid bilayer in the cell membrane. It's sort of 4-part receptor with a channel in the middle that allows ions to go into the cell. And you can see the various molecules that might be binding externally, glutamate and glycine being the primary ones here. So we'll go on to this next slide. So when the cell membrane is not depolarized, the magnesium ion that sits in that channel blocks the receptor. So the calcium ions that typically would go in when it's activated aren't able to enter the cell. This is even when glutamate and the glycine sort of coagonists are bound. It's still there blocking. Then down in C, so the yellow membrane represents when the membrane is depolarized. So once the membrane is depolarized, that magnesium ion gets displaced and then you have sort of a rapid influx of calcium into the cell. So where this is sort of the normal physiology of the cell, where ketamine comes into this story is here. So actually in the channel, and inside the channel, there's what's been called the PCP binding sites. This is where PCP, phenylcyclidine, will bind. Ketamine binds at that same place and blocks the channel in a similar way to magnesium at a very similar site. So when ketamine is there, these calcium ions cannot enter into the cell. So one of the main things, and I alluded to this before, it's a different receptor target, a different neurotransmitter system, glutamate system, than really all the other antidepressants we used previously. And this has often been referred to as the major path of ketamine's effect, the dissociative antidepressant effect. But I think the story is more complicated. I think that's coming out more and more. Other NMDA receptor antagonists have been used, like memantine and lisinopril and others, to see if they would also have antidepressant effect, and really haven't shown the same effect as ketamine. So I think the story is actually a bit more complex and not fully understood at this time. So a bit more, and I'll go through this quickly, but this is just to illustrate that there are many other things happening neurochemically when ketamine is administered. So another main sort of part of this story, it seems to be brain-derived neurotrophic factor, BDNF. So ketamine increases BDNF release, and this is supporting neuroplasticity, making new neural connections, repairing neural connections. This is thought to be a key mechanism of ketamine's effect. Monoamines, it is affecting the serotonin and dopamine release and signaling, but the relevance of this is really unknown at this time. It's also binding in the opioid system to the mu and kappa opioid receptors. The relevance of this is also unknown. There have been small studies showing that if you block the opioid system, the ketamine doesn't have an antidepressant effect, and others showing that if you block the opioid system, ketamine still has an antidepressant effect. And they're small, and this is sort of in the initial stages of being explored. So we don't really know what effect the opioid system has on ketamine or on ketamine's antidepressant effect. And some others, the mTOR complex, which is also involved in neuroplasticity, calcium channels, others. It's a complex molecule neurobiologically, how it works. So we'll move a little bit more into the clinical space. When to consider ketamine for a patient. So who meets criteria for ketamine treatment? We'll do just a little sort of quiz, and this is sort of just to get people engaged. This is going to be sort of simple presentations of potential patients who might, might consider ketamine for, and look at who might benefit and who might not, based on what we know about who responds to ketamine. These will obviously be oversimplifications, and depending on who you ask, people might have different ideas about who meets criteria. I think we use this as sort of a jumping off point to look at how to do evaluations for this. So our first patient, 31-year-old female, history of bipolar 1 disorder, had one significant manic episode 7 years ago, but it's mostly depressions that she experiences. These manic episodes are well controlled in the medication she's on, but she comes to the inpatient unit for worsening depression, suicidal thoughts, and these aren't responding to medication trials. So another patient, 58-year-old man, history of PTSD, generalized anxiety, tried many medications over the years, and none seem to really help these anxiety and trauma symptoms. So he comes in after 6 months, low mood, nightmares, intrusive thoughts, irritability, anxiety, trying other medications, and they're not working. A 72-year-old woman, history of generalized anxiety and OCD. Her husband just passed, and she's having a lot of anxiety after that. And she's taken fluoxetine for many years to help with the symptoms, but despite continuing to take this, despite intensive psychotherapy, anxiety just isn't improving. And then finally, a 51-year-old man with depression, anxiety, alcohol use, and sustained remission has had dysthymia really for most of his adult life, and then every few years he'll have this major depressive episode that doesn't really respond well to treatment. And he comes to you the past 5 months and significantly depressed, led him to have to take a leave of absence from work. And he's tried a lot of antidepressants, and they just really weren't effective. So try to keep these patients in your mind as we go through some of the evidence and approach to evaluating patients for ketamine treatment, and then we'll come back to this at the end of this section. So conditions to treat with ketamine. Unipolar and bipolar depression. So vast majority of clinical studies, the best data that we have is related to using ketamine to treat adults with treatment-resistant depression. And in addition to this, esketamine, Spravato, I mentioned before, and we'll get into more detail about this a little later. It was studied and is FDA approved to treat treatment-resistant depression and major depressive disorder with acute suicidal thinking. So a lot of evidence that ketamine is very effective for depression, treatment-resistant depression. There are also many other conditions: anxiety, OCD, PTSD, alcohol use, neuropathic pain, inflammation, autism, others that if you do a Google search and look at websites of various clinics, many will advertise some or all of these conditions that ketamine can be useful to treat, and that they will treat you with ketamine to target these. So there are many other conditions that are targeted. But an important thing to know is there's much less evidence for the treatment of any of these conditions. There are some studies in a lot of these, and some studies showing promise, but really at this point they're small, and these are preliminary data and not enough to give a strong recommendation clinically that they can be helpful. So treatment-resistant depression, we're going to focus on this as a treatment target for ketamine. And important first step, I think, is to talk about treatment-resistant depression and what it is. There's no one universally agreed upon definition. The definition that we'll use here that has been adopted really in the research setting, and most of the studies on treatment-resistant depression use a similar definition, is this one. So it's major depression that has had an inadequate response to at least 2 adequate trials of different antidepressants. They tried an antidepressant at a sufficient dose for a sufficient period of time, and it just wasn't effective for the depressive symptoms. And ultimately, up to a third of patients might fall into this category, that they're not responding to the standard interventions. So it's a lot of patients when we think about millions of people with depression. So where does some of this data come from? So STAR-D is a sort of very famous study in depression research. Many of you likely already know about this study. Some of you may not, and I'll go through it a little bit, but some of these numbers can be drawn from STAR-D. Other trials have shown similar things. But STAR-D was a large depression study looking at outpatient adults with non-psychotic major depression. And there are different steps in the study, and we'll go through this, but just briefly. So basically, they had these patients with depression, and about 3,600 or so patients started the study. They trialed them on an antidepressant, citalopram. If it worked and they went into remission, they would continue on that medication. If it didn't, they would then move to the next step, where they would either switch to a different medication, which you can see listed here in step 2, or add a different medication, or add some psychotherapy, or switch to psychotherapy. And then this process sort of repeated. So if they didn't have a remission in step 2, then they would proceed to step 3, and then on to step 4 if they're not responding to the treatment. So what sort of percentages do we see when we're sort of doing this treatment progression? So the first step on one medication, citalopram, we had about 37% remission, which is a disappearance, basically, of the depressive symptoms, which is not bad overall, really not bad. But still, many patients here are still struggling with depression. So these go on to the next step, where they're switched or have augmentation. And then of those who went to the next step, 30% of them then entered remission. Patients continue on, but then at the next step, really the response rate drops quite a bit, down to 13.7% and 13% in remission. And when you look at the response rates, which is so not as much of a change in the depression, so not a disappearance, but just a 50% or more reduction in symptoms, and both of these really not much more, in the order of 16 or 17%. And when you pull all these numbers together, the cumulative remission rate is about 67%. So this sort of supports this idea that about a third of patients aren't going to respond to our typical interventions. I think it's important to mention here, treatment-resistant depression, it's not a homogeneous condition. there are varying levels of severity and types and presentations based on the symptoms and comorbidities and the number of trials the person has failed. Many diverse types of people can fall under this umbrella of treatment-resistant depression. And there's quite a big difference, I would say, clinically between a young person with depression who's tried a few medications and they haven't worked versus someone who's had depression for 30 years and comorbid PTSD and personality disorders and have tried 12 or 13 medications and maybe TMS and ECT and just aren't responding. So both of these people would qualify for a treatment-resistant depression diagnosis, and yet obviously are very different. So, and then also just put this in here to note, like, in addition to chronic depression, which is a lot of suffering in and of itself, people with that have impaired sexual functioning and worse overall physical health as well. So treatment options for treatment-resistant depression. What is sort of the state of the field, and what do we have to offer people who present with this condition? So I think it's important if someone comes to you and are sort of, seem to meet criteria for treatment-resistant depression, important first step is just to try to confirm the diagnosis, get more of the history, see if there are comorbidities that haven't been accounted for yet, PTSD, substance use disorder that's maybe not fully known, sleep apnea, things like that. See what their past treatment trials were like. Did they take the medication for long enough at a sufficient dose to say that it was actually sort of an ineffective trial? So getting through some of this history, I think is important. But if it seems that they really have or do meet criteria for treatment-resistant depression, there are a few main strategies we have to target this. One is switching antidepressants. And usually, I'll say, usually just pick one of these strategies at a time, trial it to see if it works, as opposed to making multiple changes at once if we have the luxury of time to do that. So switch to a different antidepressant, a different SSRI, an SNRI, mirtazapine, bupropion plus minus dextromethorphan, this new medication Auvelity that it's often used. These are usually the first line sort of switching strategies. And then as people have tried more and medications haven't worked, they might move down to some of these others, tricyclic antidepressant or an MAOI, that are older medications, can be very effective, also come with more side effects, and so tend to be tried later on in the treatment approach. Another approach that's often used is to augment, so to add another medication. This could be another antidepressant, another of these that we've talked about on the left side of the screen. And atypical antipsychotic, something like Abilify can often be added. Psychotherapy, exercise, and at times things like lithium and T3. Among others. And then sort of the third major branch of ways to approach this are these interventional modalities that we have. So these are mainly transcranial magnetic stimulation, TMS, ketamine and S-ketamine, and electroconvulsive therapy, ECT. And I would say a sort of important place where these come into the treatment algorithm. So if people have very severe or highly resistant treatment-resistant depression, I think it's pretty important to start considering ketamine, S-ketamine, or ECT for these patients. So how do we know if ketamine works? What data do we have from clinical trials? I put this is, I think, a very good paper, a systematic review, meta-analysis, trying to bring together data from many ketamine studies that have been done to see how effective it might be in the real world. So this is looking at 79 studies, about 2,700 patients, pooling that data together. So simplify this slide just a little bit so we can look at the data. So pull your attention over here to the right initially. So this is the percentage of patients in these trials who met criteria for treatment resistance. This is almost 90% of the patients meet treatment-resistant criteria. So tried other medications, not working. Chances of another medication working are probably quite low, as we saw from some of that previous data in STAR-D. So when they give ketamine to these patients, they have an overall response rate of about 55%. So that means a reduction in 50% or more of their depressive symptoms. More than half of people are experiencing this, a pretty meaningful response. And then when we look at depression, so basically disappearance of the depressive symptoms, almost 30% are meeting criteria for remission in these trials. And the overall improvement is 42% in overall symptom improvement. So when we consider these numbers in contrast to some of the numbers we saw earlier, about a 13% remission rate, 16 or 17% response rate, it's much more favorable and seems much more likely that ketamine might be helpful for some of these patients who tried other medications and they didn't work. So then another question that's important is ketamine versus ECT. Which of these might you choose for a patient who really has severe treatment-resistant depression? This is a great paper published in the New England Journal about a year and a half ago now. I think it was May of 23, asking this question. So using IV ketamine versus ECT for non-psychotic treatment-resistant depression. What they did, they had just under about 400 patients randomly assigned to one of these two treatments. The patients who received ECT got 3 times a week ECT for 3 weeks. Ketamine treatment patients got ketamine twice a week for those 3 weeks at this sort of standard 0.5 milligram per kilogram dose overnight in an IV infusion. Won't go through all of the details, but I think major takeaways to have from this trial, so the conclusions from the authors, they say, among adults with treatment-resistant major depression without psychosis, sub-anesthetic IV ketamine was non-inferior to ECT. And the way the trial was designed was really to test this non-inferiority, but whether or not basically they're equivocal. And so sort of this non-inferior nature of ketamine versus ECT was supported. But when you look at one of the details of the data here, it's actually sort of a trend. You can't conclude that one is better than the other, but a trend towards ketamine showing better response. So here's the data for response rates, both the QIDS, which I believe was the primary outcome in this study, and the MADRS, showing that actually the response rates were much higher using both of those tools for ketamine versus ECT. And they actually followed these patients out for another 6 months and monitored relapse. And interesting that the relapse rate was actually notably lower with ketamine versus ECT at 1, 3, and 6 months. So this isn't to say ketamine is better than ECT, but that when they're looked at head-to-head, it stacks up well against what has long been considered the gold standard treatment. So we'll go a little bit into the specifics of the psychiatric evaluations. This is how we do it here at Silver Hill. Other places, might do it differently, but just want to give you an idea of how we're looking at patients. Sort of inclusion criteria: patients must be 18 years of age or older, have moderate to severe depression, fail to respond to at least 2 adequate antidepressant treatment trials, or have acute suicidal thoughts and depression. The reason these are the inclusion criteria is that the best data we have is that ketamine is most effective for people who meet these criteria. And there are some contraindications that I have listed here: active psychosis, primary psychotic disorder, current substance use disorder, past ketamine use disorder, things like this, things that we either don't have much evidence that ketamine could be helpful, or it's possible that ketamine could be harmful. And then medical evaluation is also how we do it at Silver Hill. Likely is done differently in other places, but I think it's good to have an idea of what we look for medically. Mostly ketamine is very well tolerated and very few medical contraindications to the treatment. So some of the exclusion criteria: significant aneurysmal vascular disease, history of intracerebral hemorrhage, pregnant, recent cardiac event, allergies to ketamine, things like this. And some of these are because for some people, blood pressure can go up during the treatment. And for some people, it can go up quite a bit. And so potentially that might be dangerous if some of these medical conditions are present. But otherwise, there aren't hard rule outs medically. But additional clearance might be needed if people have any of these clinically significant conditions. So when we're doing our treatments here, we'll have all of the patients medically cleared prior to treatment. So I do sort of basic pre-procedure clearance with labs and EKG and evaluation by a PCP, medical practitioner of some sort. And then sometimes we'll bring in some specialists, the patient's cardiologist or neurologist, if there's some other clinically significant condition that we'd like them to weigh in on. So bringing us back here to this question, these 4 patients we looked at the beginning. Give you a moment to just look at them and think, who might qualify for this treatment? Or really actually sort of who's not going to qualify. So first, so this patient is, per the criteria and the research we're just looking at, it wouldn't qualify for ketamine treatment. 2 main reasons. One, from this history, all we can tell is that they tried 1 medications that wouldn't really meet criteria for treatment resistance. And also there's no real mention of depression here. And so that wouldn't be, a target that we'd be looking to improve with ketamine. So there wouldn't be one. And of these, the other who wouldn't meet criteria would be this patient. They've tried a lot of medications and they haven't worked, so they would meet criteria for treatment resistance. But really, this doesn't seem to be a treatment-resistant depression picture here, but more of a lot of PTSD symptoms that are patients having difficulty with. And so, depression really isn't the main target here either. So these 2 patients remaining, and these patients would both meet criteria. So we'll look at them in a little more detail. And these are both, real patients, slightly disguised, that we've had here at Silverhill. So just a quick reminder, 31-year-old woman, bipolar 1 disorder, but mostly is experiencing depression. She's here with us on the inpatient unit with worsening depression, suicidal thoughts, tried some medications, but they just aren't working. She's on lithium, lorazepam, bupropion. So she tells you that when she has these depressive episodes, they completely disrupt her life. They might last for 6 months or a year before just slowly resolving. Over the years, she's tried all these different antidepressants and lamotrigine, antipsychotics, psychotherapy, just hasn't had much success. And she says, basically, once these depressions start, nothing really helps. So we see her and start her on ketamine treatment while she's on the inpatient unit. And here's her depression scores. This is her PHQ-9. And very quickly it drops from 22 in the severe range, really all the way down to the moderate range, and then very quickly into remission. We'll go into some of the details of the specifics of how many treatments and when over time a little later. But she responded really remarkably well and quite quickly as well. So our other patient, 51-year-old man with depression, anxiety, lifelong dysthymia, but every once in a while gets these major depressive episodes. And he's here after 5 months of depression, just took a leave of absence from work, trying antidepressants, but they just aren't effective. So he's also lost interest in his creative pursuits, currently taking lamotrigine, mirtazapine, venlafaxine, low doses of quetiapine and lithium, not really improving, and he's just worried this isn't going to get better. So here's some of his, I'll show you some of his scores for both depression and anxiety. And obviously the stories are much more complicated than this, but this gives us sort of a good snapshot of how their symptoms are trending. So first, the depression scores, the PHQ-9. So we start sort of in this moderate to moderately severe range. And I think given having to leave work, I think that sort of adds to the severity here of what the depressive symptoms that he was experiencing were. And he pretty quickly drops down into remission as well. Then time goes on, there's a life stressor that arises, depression sort of pops back, but then able to get it under control again. And we'll go through some of the specifics of how we do this a little later on as well. And then here is anxiety scores. So we're not targeting anxiety directly, really, with the ketamine treatments, but what we see is patients who have depression and comorbid anxiety, which is very often the case. It's not infrequent that the anxiety responds well also, and that the anxiety will improve quite a bit over the treatment course. So you can sort of see his anxiety coming into remission as well. So administering the treatments, let's look at some more of the specifics of how we do ketamine treatments. So begin here, ketamine versus S-ketamine. It's an important distinction to make to understand a bit about what we mean when we say these two words. Please forgive me, but we're going to talk a little bit about some organic chemistry to understand the difference here. I've shown an image here of the representation of what we call racemic ketamine. When people say ketamine, they typically mean racemic ketamine, which is a 50-50 mixture of two mirror image isomers of ketamine, S-ketamine and R-ketamine. So what does all this mean? I think one easy way to think about it, and what it's often referred to as S is referred to as the left-hand isomer, R as the right-hand isomer. And in the same way that your hands are sort of mirror images of each other, and that if you transpose them directly, your thumbs are kind of sticking out in alternative planes. If you sort of make a mirror image, flip your hands around, then the thumbs are sticking out in the same plane. So three-dimensionally, they're organized slightly differently, and in a similar way, many molecules in nature, ketamine being one of them, the two enantiomers are organized slightly differently in three-dimensional space. And so I'll show this little red dot here is labeling what we call the chiral center. So it's around this point that the four kind of molecules that attach are arranged slightly differently in three-dimensional space. And this is important because of that shape, the molecules might bind slightly differently to some of the nooks and crannies of receptors and might have slightly different physiologic properties. So when we say ketamine, this is when people are getting IV infusions of ketamine. It's typically the same racemic ketamine, sublingual lozenges, intramuscular injections, also this racemic ketamine. When we talk about S-ketamine, this is slightly differently, and this was developed by Janssen Pharmaceuticals. And what they did is basically they isolated just the left-hand version of ketamine, the S-ketamine portion of the racemic mixture. So it's 100% S-ketamine. This was then placed in a nasal spray and is administered as Spravato. Part of the reason for this is that ketamine is a very old medication, and so not really patentable. And also with S-ketamine, there's a thought that the S-ketamine is a stronger antagonist of the NMDA receptor. And so there's sort of this thought that potentially it's the more effective as an antidepressant, and potentially there might be less side effects if you can just administer this one enantiomer. So I think there are different, maybe scientific and commercial interests that went into this development. And this is not an abnormal thing in our world of medications, psychopharmacology. So very common medicines that we use, Celexa, citalopram, Lexapro, S-citalopram, have a very similar biochemical relationship, where Celexa is the racemic mixture of left and right, the Lexapro is just the left hand. So what are some of the differences in how it's administered? We'll focus on the IV ketamine versus intranasal ketamine here, because these are really the two that have been best studied and are often used. So with IV ketamine, the dose, the typical antidepressant dose is 0.5 milligrams per kilogram infused over 40 minutes. Most all of the controlled studies that have been done showing IV ketamine has been effective have been done at this dose. And granted, there have not been a lot of great dose finding studies. So, I think more work could be done in that area, but for now, really the best evidence is this dose. Higher doses, like if you're getting up to 1 milligram per kilogram, don't seem to be more effective. And then as you get to lower doses, 0.2 milligrams per kilogram, they don't really seem to be effective at all. And then the intranasal ketamine, the doses really just has three main doses you can use, 28, 56, or 84 milligrams. And the monitoring, so with IV infusion, patients get the infusion in the clinic and typically have to stay 20 to 60 minutes afterwards to come back to their normal mental status. And this length of time, it's variable. It's determined by each independent clinic. There's not set regulation around this. With the intranasal esketamine, patients must remain in the clinic for at least 2 hours after the dose administration. This is very strictly mandated by the REMS program. So treatment course, how many treatments do patients need? How often? How often do they need to come back? How does this look? I think if you were to ask 4 different clinics, you would probably get 4 different answers as to what the treatment course needs to be. It's very regulated, or it's just more standardized, I should say, for esketamine, but for other approaches, really there are many approaches that are used. We don't have great data really to know what the best treatment course should be. So generally there are 2 main approaches people use: a symptom-driven approach and a more like standardized approach. And if we look at this spectrum, so sort of the smaller independent clinics tend to lean towards this symptom-driven approach. And then the esketamine clinics are more on the standardized side, and then others can fall sort of all along the spectrum. So on the symptom-driven side, just generally, what happens, people will get twice-a-week infusions for 3 weeks. And then hopefully they're doing a lot better. Hopefully the depression is improved. And then maintenance treatment, we know this isn't a treatment that lasts forever. Typically, once the treatments are concluded, at some point in the future, the depressive symptoms are going to come back. So maintenance, this ongoing treatment to control the depression, is scheduled really based on symptom return. When symptoms start coming back, when the person starts, they're slipping back into depression, they call, schedule their treatment, come back in for their treatment. And then discontinuation can be, quite variable depending on the clinic and, how fast the person wants to discontinue or not. On the standardized side, which is what we're doing at Yale when I was training there, what we're doing here at Silver Hill is much more similar to the standardized side. We do sort of the induction period twice weekly for 4 weeks. And if the person is having a meaningful response, depressive symptoms are getting better, suicidal thinking is going away, it seems like the ketamine is helping, we advise continuing the treatment, but at a sort of decreasing frequency to basically titrate the person off and become stable at lower and lower frequencies of treatment. So they go down to once weekly for 4 weeks. And then it becomes a lot more clinically variable with the maintenance phase, depending on how the person's doing, how their symptoms are responding. We try to space it out slowly to every 2 weeks for a few treatments, every 3 weeks for a few treatments, out to every 4 weeks. You can even get farther out than that, but hopefully to get the person stable on like once-a-month treatments. And then eventually discontinue after, think about discontinue after 4 or 6 months of recovery. To give them a long period of doing well, reestablishing a lot of the habits, both behavioral habits, psychological habits that help keep people well, reestablishing social connections, all these things that people sort of lose in depression. Give them a good chance to build that back before stopping the ketamine treatment. And then there are all sorts of hybrid kind of schedules, both in between and just different approaches to the treatment. So when we look at ketamine versus esketamine, which is better? How do we choose between these two? So here's a good study that compares the two. It's apples to oranges, very different studies. You don't have any head-to-head comparisons, but this is the best we have right now to look and try to ask this question. So review, meta-analysis, looking at the comparative efficacy of these two medications for unipolar and bipolar major depression. So the findings, 24 trials were brought into the analysis, almost 1,900 patients. What they found is racemic ketamine relative to esketamine demonstrated greater overall response. You can see the relative risks here, almost double or a little more for racemic ketamine versus esketamine. Actually lower dropouts for ketamine as well. And so the author's conclusions here: IV ketamine appears to be more effective than intranasal ketamine for the treatment of depression. And then here's just visualization of the data, the remission rates. And we won't talk about this too much, but just to show, so this is the ketamine studies. There are more studies, but they tend to be smaller, larger confidence intervals here, which tends to happen with smaller studies. And then esketamine, there are fewer trials, but bigger trials. The size of the blue square sort of represents how many patients were in each of these trials, and much more narrow confidence intervals on these larger trials, which is what one would expect. So look at some of the pros and cons of these two treatments. So IV racemic ketamine dosing is a lot more precise. It's an IV, you know 100% of the medication is getting into the person, and it's a lot more flexible. There's a lot more variability in the weight-based dosing you can use. The intranasal ketamine, the dosing is less precise. It's hard to know how much is being absorbed through the nasal mucosa. I've heard numbers anywhere from 25 to 50% of the dose is actually absorbed. This can differ based on how the patient administers the dose, allergies that day, other things like that. And it's less flexible. You really just have 3 doses for the patients. And I'll move through this sort of quickly, but it's easier to stop treatment with IV ketamine, with intranasal. Once the treatment's delivered, you just sort of have to ride it out if any negative adverse reactions occur. As the data we just saw, possibly IV racemic ketamine has a better response versus the intranasal ketamine. Medical professionals are present typically at both of these treatments. They're required intranasal ketamine ones, which is great for safety, a lot less regulatory oversight on IV racemic ketamine, not much oversight at all, really. There's no REMS program. Intranasal ketamine, pretty tightly regulated through the REMS program. Racemic ketamine, not FDA approved for any mental health condition, approved as an anesthetic, as we discussed earlier. Intranasal S-ketamine is approved for both treatment-resistant depression and major depression with suicidal thoughts. And then as we saw earlier, for smaller, less rigorous trials on the ketamine side, larger, more rigorous trials on the S-ketamine side. And then finally, ketamine is a generic medication, very inexpensive, but very little insurance coverage as well. It can be difficult to obtain. Intranasal ketamine is branded medication, much more expensive, but fortunately, since it's FDA approved, insurers are much more likely to cover it. So often sort of the out-of-pocket cost for the patient is much less for intranasal ketamine. So at-home ketamine is an important thing for us to touch on here. There are many treatment providers that will send ketamine to patients in their homes to use. This arose with some of the relaxation of regulations in the COVID pandemic around prescribing controlled substances and not having to meet a person in person prior to prescribing controlled substances. So with that, this sort of at-home telehealth ketamine industry arose. And there are many different companies that do it. You do a self-assessment often, meet a medical provider, they do an evaluation, and if they seem appropriate, then they'll send you ketamine to your home and you dose yourself with typically sublingual lozenges. This is another company, Mind Bloom, that does it. They'll send you a Bloom box, this box that contains everything you need, a journal, an eye shade, blindfold, maybe a blood pressure cuff, medication. And there are many other medications, the New Life, Better You, WonderMed, these are some others. And I just direct you, I think there are much increased risk with this at-home dosing. The FDA issued a warning about a little over a year ago now, basically saying with some of these telehealth platforms, there's more risk of abuse and misuse, psychiatric events, other medical concerns that might arise in the treatment. And this risk really because there's not a health provider available. And then if you want to learn more, this is an interesting article a year and a half ago in the New York Times, looking at this industry and some of the challenges that have arisen because of the at-home dosing. So some of the side effects and risks, for the most part, ketamine is quite well tolerated, and side effects tend to be minimal and expected. So most of the side effects will both arise and resolve in the sort of 2 hours or so that the patient is with you in the treatment center. It's going to be headache and nausea, some increased blood pressure and heart rate, which is typically pretty minimal, but for some patients can go high, and we monitor that. Drowsiness, dissociation, anxiety, tiredness. We'll talk about the sort of altered mental state in a second. In the more medium to long term, ketamine misuse, ketamine abuse, developing a ketamine use disorder is something that is possible and something that we worry about and watch out for. And in the longer term, lower urinary tract symptoms, frequency of urination, pain with urination, things like that. And then in populations who have had chronic abuse of ketamine, high doses, quite often, much more than people would receive in a clinical setting, interstitial cystitis, very serious inflammation of the bladder, which can be as serious as causing people to be unable to urinate and need to use a urinary catheter, and some memory cognition issues as well. I think importantly, these risks tend to be mitigated with appropriate screening, psychiatric and medical, and controlled administration with healthcare providers present. And the altered state of consciousness. So I'll talk a little bit about this as well. So I see all of our patients both before and after all the treatments. And probably every day, someone will tell me this. It's really hard to describe the experience with words. So I'm going to use some words to describe this experience, but please forgive me because I'm not going to be able to do it justice. So dissociation is typically referred to as a dissociative anesthetic, but I think this is sort of a somewhat misleading label and just captures a part of what the experience is like. This idea of a dreamlike state seems to better capture what the experience is like. And this was actually the first label or the first way of describing the experience that was came to mind by Domino, the person who actually discovered the ketamine molecule. So what are these different things people could experience? Often a calm, peaceful feeling. The vast majority of treatments that we do are quite pleasant for people. People have a floating sensation, feel separated from their body and the environment. And this is where some of the dissociation can come in. They can experience very intensified emotions, joy, sadness, the full gamut, really, and intensified present moment awareness. Sometimes anxiety, fear, disorientation can arise, and it can be difficult experiences at times for people, especially when difficult psychological material is coming up in this intensified way. They can be challenging, and it's good to have people around to be supportive of them in those times. Often people can have a quieting of the internal monologue, this sort of negative ruminative voice that is so often present in depression, and kind of fade away for a while, which can be both interesting and insightful for the person. It can be very visual. We have all of our patients wear eye shades. We give them headphones with noise canceling ability and a playlist that we've carefully put together to support the experience, to sort of keep them very internally directed with their eyes closed. In their mind's eye, it can be a very visual experience, seeing lots of colors, shapes, textures, things like that. It can be a very visual experience. People can be from moving through landscapes or environments, can be exploring their life, reflecting on things that have happened, good and bad, and sort of sometimes seeing them in a new light. And there can often be moments of insight. It can be a very meaningful experience. It can be very random and seem to not have any meaning at times, but typically it's quite an interesting experience for patients. And this patient, who is our young woman with bipolar disorder, she said, ketamine therapy changed my life because it allowed me to distance myself from my negative thinking in a remarkable way. So set and setting, and I'll go through this sort of quickly so we can leave time for questions. But this is this idea that, in psychedelic medicine, I think it's important in ketamine. Ketamine sort of broadly falls under this umbrella of psychedelic medicines. The mindset that the person is bringing into the treatment, who they are and the preparation and things like that is important to what actually happens during the sort of dreamlike state, and the setting itself, both the clinic setting, the staff that are there, and kind of the larger cultural context affect the subjective experience of the treatment. So I direct you to this paper if you're interested. It gives a really good history of set and setting. And sort of good frame of thinking about it. But in our clinic, we tried to really maximize the positive effects of set and setting with having a calm, sort of living room type setting, but still with medical equipment and, given that it's a medical procedure, and helping people feel very supported and seeing providers before and after the treatment and everything like that. And I'll also just mention this, music can also be a very important part of the treatment. It's really amazing talking to patients who have had treatments without music, with their eyes open, looking at their cell phone, texting, versus an experience with eye shades on, listening to music, fully engrossed in that space. It's just the same dose, same treatment can be just drastically different, and really so much more meaningful and powerful when with the sort of eyes closed, music supported experience. And there's even lots of work in this space. Here's a good paper sort of music sometimes being called the hidden therapist and how it plays into these treatments. So some proposed mechanisms of action. This is just sort of a simplification and a generalization, but I'll often explain it to patients in this way, that there are sort of three main ways ketamine can be helpful. One is just reducing symptoms, sort of biologically making people improving their mood, decreasing suicidal thinking, decreasing anxiety, supporting change, so helping to create this state of neuroplasticity, increase BDNF release, helping with psychological flexibility, things like that. And then this facilitating insight, potentially a lot of it from the dissociative dreamlike experience. Looking at new perspectives, seeing their mind in new ways, amplifying feelings, supporting mindfulness, things like this. So there's different ways and there's different planes that it's working on. Some more on the biological side, some more on the psychological side. And this, I put this here just as sort of an anecdotal account of ketamine response. Patients I've seen that seem to respond well, and not necessarily these are the only ones, and this isn't really research-based, but just as a way of thinking about patients psychologically and how they might benefit from these treatments. So often patients with uncomplicated depression, quote unquote, people with depression and anxiety without other significant comorbidities and other things in life are going relatively well, they seem to have a higher chance of responding. There's just less complicating factors in the treatment. People with life transition, ongoing, they've had lifelong depression, but currently sort of in the midst of their worst episode because of some big life event, retirement, divorce, death, things like that. It can help with sort of reframing and thinking about things in a new way. Cognitive inflexibility is sort of a similar thing. So depression, it's just very ruminative, negative thought patterns that are consistently with the person. They sort of are stuck in this way of thinking and can't get out of it, and it's sort of depressogenic, if you will. Ketamine can help with kind of breaking these thought patterns and helping them hopefully to move into other ways of thinking that could be, better for their mental health. And then people with behavioral deactivation, just hard to find the energy to do things, get out, daily tasks, stuff like that. It can help to motivate that. And ketamine and psychotherapy. So this is still sort of an area of ongoing research. People are looking at this. There's this idea that psychotherapy can help and potentially extend the effects of ketamine. Still, I think a lot of work to be done in this space, but just to briefly look at it. So there's some different ways that psychotherapy can be applied with ketamine. One is this, what we might call a psychedelic therapy approach. So you can see here in the red, this is the sort of the ketamine session itself, done at a higher dose to produce sort of an altered state of consciousness. The therapy is represented by the solid black line. So the therapy is really happening before the session and after the session, but during the session itself, the patient is very sort of internally directed. This is how we do it here at Silver Hill. A psycholytic therapy approach is a slightly different approach where the dose tends to be lower. You can see the red dosing session here, and the therapy is sort of happening throughout. So when the patient gets the dose of ketamine, which is lower, often sublingual, they aren't wearing eye shades, aren't listening to music. They're probably interacting with the therapist during the session. It's sort of seen as a psychological loosening agent. So these are what, and I refer you to this paper at the bottom of the page if you want to learn more, but what's called an experience-oriented approach. So thinking that the experience of the ketamine itself can be helpful, a source of meaningful experience, a source of learning, and it is not just a troublesome side effect to be mitigated. Another approach is the so-called plasticity-oriented strategy. So you have the dosing session here at the beginning, and then the psychotherapy in the black line is really taking place after. With this idea that a lot of the cognitive behavioral approaches will take this approach, with the idea that ketamine can induce a state of neuroplasticity. In a state of neuroplasticity, psychological change likely will be easier and supported by underlying biochemical changes. And so doing psychotherapy along with that would make that psychotherapy easier and the chances of change better. So pulling it all together, another model, which is an interesting model, this Montreal model of ketamine for treatment-resistant depression. I'm going to click through this pretty quickly so we can get to the final slides and then to questions. But this gives a good overview of how treatment might be done in one model and in a detailed way. So initially there's a psychiatric assessment, medical assessment, making sure the person is appropriate for the treatment. If they are, they would then go into some preparation, psychoeducation, mindfulness training, and they start psychotherapy at this point. So this sort of plasticity-oriented approach where the training is, the psychotherapy is sort of happening weekly in the background, but not necessarily a part of the ketamine treatments. And then the ketamine series itself would start, and then each one, this is a bit more of the psychedelic approach actually with it. So you sort of have both of the psychotherapy approaches. So highlighted here, each session, you sort of check in, discuss the previous session, establish some intentions and goals for this ketamine treatment today, do the ketamine infusion, which is supported by music or mindfulness exercise. And then afterwards, check in, do a little bit of debriefing, and then get ready for the subsequent sessions. And they call this rolling preparation and integration. Preparation being getting ready for this session, integration being sort of integrating some of the things that arose afterwards. They do treatments twice a week the first week, twice a week for the second week, and then they start spacing it out from there to once a week for these next treatments. And then they really don't do much maintenance. Actually, they would just continue normal treatment and have the patient come back in maybe 4 or 6 months if they wanted additional treatment. So a few more things to wrap us up. So let's come back to our patients. We've looked at a lot of what's happened so far. This is our young woman with bipolar disorder on the inpatient unit with depression. We've seen how her depression scores already have gotten a lot better very quickly. So we'll bring in some of the other aspects of the treatment. So it's in this initial phase. This is when she's getting twice weekly for 4 weeks. So in these 4 weeks, she's going from severe depression, basically to remission. And within the first three treatments, she'd improved enough to be discharged from the inpatient unit and continue the rest of this as an outpatient. Then we go on to once weekly for 4 weeks. And then after that, spacing it out every 2 weeks, every 3 weeks, every 4 weeks. And then she stays stable here in a remission range for 6+ months. And then eventually discontinues not long after this. So she credited ketamine for her significant recovery, left her previous stressful job, found new work in a field she was much more excited about. And friends and family noticed this too, and they told us and her that this was the best she'd been doing in 10 years. So really encouraging and really an amazing response for her. And our other gentleman, 51-year-old with this lifelong depression, but intermittent and major depressive episodes here with 5 months of depression. It's not getting better with medications. Here's his twice weekly for 4 weeks. So he doesn't show huge improvements, but it's just starting to show these improvements at the end of the initial 4 weeks. And right after that, this once weekly session, he kind of falls down into the remission range and is doing well. We're spreading it out to once every 2, once every 3 weeks. And it has sort of semi-big life stressor, and the depression sort of starts to come back. And so there's some flexibility clinically with what we do here. We moved him back to twice weekly for this time period. Started to get better, and then start to space it back out again. And saw him recently. He's doing really well, and just on once every 3 weeks treatments right now. So he's now back at work, returned to his creative pursuits, submitted a piece of art to a competition, and has stopped lithium. So sort of simplifying his daily regimen without any issues. So last slide here. So we started out, what have you heard about ketamine? All these big headlines, horse tranquilizer, recreational drug that is sort of tragedy of Matthew Perry, all of these things that many people have heard about. And I hope through today we've added some more to this story of ketamine to give us, a more well-rounded picture of where this medication should fit in our world. Looked at a lot of treatment studies. Thousands of patients with depression have gone through studies of both ketamine and esketamine and had really good results and really positive responses to their depression. We've looked at some of the biochemistry, the neurobiology of these medications, this medication, how it works in the brain. Looked at different treatment approaches, IV ketamine, Spravato, at-home ketamine, some of the pros and cons of each of these. Talked about set and setting and music and the dissociative experience itself. And then also, and most importantly, looked at a few patients, real world patients that we treated here who have done really well with ketamine treatment and benefited a lot from having this treatment available. So with that, I will end the presentation and open it up for questions.
Amazing presentation. Amazing. Can you hear me okay? I think I froze apparently in the first one. Am I introducing you? So I want to make sure I switched places. Can you hear me okay?
Yeah, I didn't know if that was you or me.
It was me. So you were loud and clear. So thank you, William, for an amazing presentation, for which so far we have 31 questions in the chat. So we'll see how we can get through them all. And please go ahead and continue to put questions in, and we'll get to what we can. And I'll group some for the sake of time and efficiency. We are now up to 35 questions. So let's go for it. Dr. Pruitt, there are many questions in here around kind of comorbid like addictions and the role of using ketamine for patients who historically have an addiction or who have ongoing addictions to substances. This question here from Andrea Rothberg is a good one to start with, I think. I've worked historically in addiction treatment, and this is something that we typically wouldn't recommend for people with addiction issues. Can you comment on this and any research data that supports benefits of this for those with addiction issues?
It's an interesting and good question and comes up a lot. I mean, there's some pilot studies looking at using ketamine to treat basically active alcohol and cocaine use disorders. It's very preliminary, showing some positive responses. People are looking at this just for treating acute addiction issues. The way I think about it, I think if someone has a substance use disorder and it's been in remission for a long period of time, they're continuing depression. I mean, often people have these comorbidities, they come together quite a bit. If the substance use is well controlled, I think ketamine is a reasonable thing to consider if they're meeting criteria for treatment-resistant depression. Substance out of the picture, the depression is continuing, nothing's working. But I think it's important to counsel them, to talk to them about the substance use risk that's there, that people develop substance use problems with ketamine and can run into all the same problems that other substance use disorders might cause in addition to others. And so to let them know that, but I think it's a reasonable thing to consider, and then just to watch. Usually if someone is in like a sort of an acute episode of substance use, if they're continuing to use substances, we wouldn't treat them with ketamine for multiple reasons. But one, for I think the risk is likely higher there of developing ketamine use problems, but also with ongoing substance use, it really muddies the waters diagnostically in terms of like, is this a depression, treatment-resistant depression picture, or is the ongoing cannabis use, ongoing alcohol use, or whatever it might be, really causing all these symptoms? And if a person could achieve sobriety, then maybe they'd be doing a lot better from that perspective.
Right. In thinking about this more specifically, there are some questions about opiate use disorder, and one here specifically for patients who are receiving methadone or Suboxone. Is that somebody who you would consider for ketamine treatment? Or what do you think about that?
It's a good question. We haven't had anybody actually in our clinic on methadone or Suboxone maintenance coming through for ketamine treatment. I think it wouldn't be necessarily an exclusion, depending, on the specifics of the person, on how long they've been in treatment. As we know, this medication-assisted therapy for opiate use disorder with one of these substances is really one of the best ways for someone to maintain their sobriety, to stay stable. And so I don't know if you'd have to absolutely not consider them for the treatment, but I think it would be a much more careful consideration, discussing with them, family, their psychiatrist, and anyone else who might seem, who's involved. And depending on the severity of their depressive symptoms too, the mild depression would be a different thing than like very severe depression and suicide attempts and things like this. The sort of the risk benefit evaluation would sort of change depending on the clinical picture.
But there's so many questions about this coming up. Just to be clear, is there evidence around using ketamine for opioid use disorder, or it's in and of itself?
Not that I know of.
Mm-hmm.
I'd be happy for you to tell me about some if you know about it.
And, great, somebody could type that in. Can you say something about the risks of ketamine in relation to suicide and how this compares to the risks of other antidepressants?
So it's an interesting question there. So like the S-ketamine FDA label carries the black box warning, just like other antidepressants, of this potential for increasing suicidal thoughts. And I'm thinking assuming this is what you're asking about, sort of increasing the risk of suicidal thoughts after starting the medication. So it's there, as with all of our other antidepressants. And also, I think, similar in that when someone has depression and suicidal thinking, best way of mitigating those depressive symptoms, decreasing the risk, is by using antidepressant medications. And also ketamine really has pretty robust anti-suicidal properties, is even, the esketamine is FDA approved for depression with suicidal thinking. So I guess sort of the risk is there potentially, but really the potential benefits of it decreasing suicidal thinking, I think is much, much higher.
Great. There's a lot of interest in this, Dr. Pruitt. There are 48 questions so far. I think the most I've ever seen since we've been running our Grand Rounds programs, and they keep rolling in. So here's a question for you. Can you elaborate a little more on how response rate is defined in ketamine treatment?
Yeah, so there's response rate as it's defined in research studies, which is sort of 50% or more reduction in depressive symptoms, as measured by the QIDS or the MADRS or whichever other measure they're using. I think, as you probably all know, these are measures of some part of depression, some part of a person's life, but there's a lot more to what's going on with the person and how to conceptualize whether or not the ketamine treatment is meaningful for them. So usually what we'll do and think about is, there are some different inputs we'll use. The patient self-report, talking about how much their depressive symptoms seem to be improving, if their activity in life, getting back to work, engaging with others, if this is getting better, looking at their depression scores through the PHQ-9, their GAD-7 anxiety scores, how's their suicidal thinking doing, talking to family members or talking to patients about how the family members feel like they're doing. So if you have a loved one who says you're doing much, much better, or there's really no change, that's another sort of good data point to bring into this evaluation. And then also, our clinical evaluation of, does the patient still look extremely dysthymic, slowed down, not doing well, or is their affect just brightening a lot? Are they joking with us? Are they more engaged with us? So taking all these data points together, just sort of to try to create an understanding and then discuss with the patient of whether or not it seems like the response is meaningful and helping them and moving their life in the direction they want it to. And sometimes this is very clear that it is, sometimes it's very clear that it's not, and then a lot of times it's sort of in the middle. And so it's a collaborative discussion to figure out how to continue the treatment, whether or not the person wants to.
Great. Dr. Pruitt, there is a question here then elaborating on that a little more. What's just been your either anecdotal or follow-up experience in terms of the response to ketamine of people that you've taken care of at Silver Hill?
So two parts. So some people we treat and they stay with us. Other people sort of start with us on the inpatient unit but might live somewhere else in the country, and so then they continue treatment somewhere else. So a lot of people I don't actually know how they do in the longer term if they sort of move away and continue treatment somewhere else. But for the patients who tend to continue with us, the rates seem to be sort of similar, or maybe a little even better with the response rates compared, like in that data I presented with the systematic review of IV ketamine treatments, where it looks like where the response rate's like 55, 60%, and then remission sort of a third or a little less. So, there's probably 25% or so of patients who are moving towards remission, 25% who really aren't having any response at all. And then the other 50 falls somewhere in the middle in this sort of spectrum. And then that's where we're kind of working with them to decide, has this made a meaningful enough change to continue? But yeah, probably in the 50 to 60% at least are having, quite a meaningful response to the treatment.
Wow. So then there's another question here, and I'll just go. Then I think probably a natural question from that. Why not consider ketamine as a first-line primary treatment for depression?
This, it's a good question. There's some downsides, but I do think so. ketamine ends up in this place down the treatment algorithm where it's like this severe last ditch effort, sort of heroic effort to try ketamine treatment. Um, and I think, I don't know that it needs to be seen that way. I think it doesn't need to be first line, I wouldn't say, but I think moved up in the treatment algorithm quite a bit could be reasonable. For the most part, it's quite well tolerated. In a lot of ways, the side effects are a lot less than other antidepressants, where people take them every day and build up a steady blood level and develop these some various side effects with the ketamine. It's in and out of your system quite quickly, and so it tends to be pretty well tolerated. I mean, there is the risk of misuse that could arise. And mainly some of the like cost and logistical concerns I think are there, that it can be a burden for people to come twice a week to the clinic, and you can't drive yourself home and you can't drive for the rest of the day. So it's sort of big. It can be difficult for people to get here, and then the cost can be quite high. Also, depending on insurance and the form of ketamine you're getting. So,
Got it. There's a question here. You mentioned misuse, and calls my eyes to a question here that says, Dr. Pruitt, how to prevent addiction to ketamine with treatment duration, intensity of dosing? Does that make a difference? What do you think about that?
So it seems like one of our main protections against misuse, decreasing diversion, decreasing a person's risk of developing a substance use problem, is using controlled clinical administration of the medications, delivering them in the clinic, monitoring the person. The person goes home, they're not getting take-home doses. There is a danger with at-home doses that people can get prescribed more, keep getting it despite issues they're having, get prescribed from multiple prescribers, and then be using higher and higher doses and developing these challenges. Because typically in the clinical setting, like what we're trying to do with those treatment kind of approaches that I was showing, it's more intensive twice a week at the beginning, but the goal is to space them out to less and less frequent treatments. And really almost use the ketamine as like a catalyst initially to help with their depression. They're usually continuing other medications in the background and continue these, and then make it less and less frequent over time. So I think that probably is our best protection against this, but I think that, the risk is still there, and people can sort of potentially develop a liking for ketamine in the controlled clinical setting and then seek it out outside of the clinical setting.
Great. Thank you. So there are some questions here now appearing around, a few just appeared around the question of stigma and how you counteract stigma in having a discussion or beginning about ketamine or wondering about ketamine with a client. Have you run into that, of stigmas around ketamine, or what are your thoughts about that?
I haven't as much with the patients who come interested in the treatment. One this is sort of a tangential
Sure.
thing to the question, but a lot of times when patients have treatment-resistant depression, come in for like an interventional evaluation to see if something like ketamine, TMS, ECT might be appropriate. But I see stigma coming into the picture more as tends to be stigma against ECT, which pushes people towards ketamine a lot of the time. So ketamine seems to be more acceptable from patients I've talked to, given all the news coverage and things like that. So I haven't encountered too much stigma against it.
Great. There's a question here wondering about comparisons with TMS and what you might know about that. We saw the data in comparison to ECT, but what about TMS?
It's a good question. I don't know of any direct comparisons between the two, or systematic reviews comparing them. If you have some, please send them to me. I'd be happy to see it. Sometimes they're different. Sometimes we'll think of ketamine for patients with, if they have more severe depression or needing a faster response, have really acute suicidal thinking, sometimes pushes towards ketamine. To TMS, a little bit more depression is not quite so severe, or usually with the approaches that take weeks and weeks of treatment, the slower response is acceptable.
Great. Can you talk to us at all about comorbid personality disorders? If somebody has borderline personality disorder, is this just as likely to work? Might it work just for that? What's your experience or knowledge about that, Dr. Pruitt?
I think it's definitely not an exclusion. We have plenty of patients here who have comorbid depression and personality disorders, often borderline personality disorder. I think, and I'll talk to patients about this before. I think the chances of sort of having a home run treatment where the depression goes into remission are lower when they also have comorbid borderline personality. The depression can still get a lot better. It can still respond. Sort of the personality challenges remain. But sometimes those can become less severe when the depression isn't so much in the picture anymore. And then, and I don't necessarily have data for this, but if we take this idea that ketamine is helping with psychological flexibility, making psychological change, gaining insight in the psychotherapeutic process and psychotherapies that tend to be, a major effective intervention for borderline personality. If it's supporting that, common sensibly, I can see how it could potentially help.
Great. I guess along the similar lines, you showed us those 4 cases and you X'd out 2 of them as really not fitting into the criteria that would be used here. But what do you think about people who struggle with generalized anxiety disorder symptoms? Is there any evidence that ketamine is helpful?
Not nearly as much as there is for depression. So often they come together, the depression and anxiety. One might be primary and driving the other, but they do very often come together. But we tend to not really use it for anxiety in and of itself. I know there are many clinics that use it, and I can't say necessarily that it doesn't work. It's possible that it does, but I think more controlled trials are needed to really say that with much certainty.
Great. I'm having to sort through questions here because through the many thank yous for a great presentation that are here in the chat. So let me say that out loud. Thank you for a wonderful presentation. Then there's a great question here. It says, is there any data on use in adolescents? I know over 18 was one of the criteria, but what do we know about that?
We don't know as much, but some treatment centers, some of the larger treatment centers, like I know Yale and Mass General, will treat patients at least down to 15, potentially younger. People will treat younger patients with ketamine. Again, a lot less data there to say whether or not it's effective, whether or not it's safe. I don't know that we have anything to suggest that it's not necessarily. But at least here, we've made the decision at this point in time to limit it to 18 or older, just because that's where the vast majority of the studies have been done. But there are places, very, very good places like Yale that will treat younger people.
Great. Another interesting question here about the use in psychiatric emergency departments. And I wonder, is that a model that's used everywhere where someone would come in with symptoms and actually receive ketamine in an emergency room setting?
I've heard that of like studies going on to, I don't actually know what the results of those studies were, but looking at people coming in with depression, acute suicidal thinking, and like, does it make sense to give them a few ketamine infusions while they're here with us for a few days and then see if they can stabilize enough for outpatient care? I know that's something people have looked into, but I don't know how widespread that would be right now.
And there are some logistical questions also in the Q&A. Can you just review a little bit if what a typical ketamine session would involve in terms of really kind of the time of administration and recovery, and what would happen at home, and would people go to work the next day, or what are the logistics of that?
Yeah, so usually people would arrive at the clinic, we give them some paperwork to do, questionnaires, things like that, bring them back. I would meet with them, just check in, see how they're doing, do a little preparation for the treatment that day. The ketamine nurse here who places an IV, gets them ready for the treatment, talk a little about dosing, and then we have them go back to the treatment area, get them set up with the eye shades, the headphones, get the ketamine all ready and in the infusion bag, and then that would get sort of set up an IV pump to get done. The infusion would be 40 minutes. They'd stay with us another 60 after that to sort of come back to the normal mental state. Most people are basically back to normal about 30 minutes after the infusion. Some people take longer, but they wait those 60 minutes and they go home. They can't drive themselves home, so either a loved one or when they're more experienced with the treatment, take an Uber home. And really later in the day, most people are doing pretty well, mostly back to their normal selves. The main complaint we have is people feel a little tired. But some people will even go back to work later that day if they do sort of work from home on the computer. Advise people not to use heavy machinery, work from heights, things like that. But people mostly feel pretty much back to normal later that day.
Right. Um, Last question. I know we're right at time here, but are we aware of any long-term side effects like with ECT potentially? Are there things that patients should worry about?
It's a great question. Something that's still being explored. The best data we have for this is really just Spravato, S-ketamine, where they've followed people out for years getting ketamine treatments. They sort of got this acute series with twice a week and then once a week, and then sort of randomize them to placebo or continued treatment. They'd get treatment every week, every 2 weeks for years, and follow them up to watch for relapse into depression and also any additional side effects. And looking specifically at some of these side effects that we know about, like the interstitial cystitis, significant urinary issues, cognitive issues, they didn't see any worsening of that over the years of these people getting quite frequent weekly or biweekly treatments. So I think it's all very encouraging.
Great. Well, Dr. Pruitt, thank you so much for your expertise, for sharing everything really that you know. That's, I don't know, it's very fortunate and helpful for us to be able to spend this time together with you. And thank you, everybody, for joining us today, for joining us throughout the year in 2024. Like I said earlier, we have a full schedule that's marked out for 2025, and we have some outstanding speakers from around the country who will be joining us. So hope you can join us when we start again on January 8th. And until then, happy holidays, everybody. Hope they are great. And here's to a wonderful next year. Thanks again, Dr. Pruitt.